Walter, you can proceed with the introductions. And Dr. Malloy, you're on mute.
Good evening, everyone. Thank you very much for joining us today for this webinar by the Young Nephrologists Committee, which is going to be presented by Dr. Musarakatani from Botswana. She's being supported by Professor Lazarus from Red Cross Hospital in Cape Town. And to start, I'll give you a brief introduction of Dr. Musarakatani. I'll introduce both speakers at the beginning. And during the presentation, if you have any questions, please be at liberty to ask the questions on the chat box. They will be answered at the end by both presenters. And I know we have also other people in the chat box who will also be interested in actually having some input. We'll also see if we can actually add them into the panel as we go on. I'll start by introducing our speaker for tonight. Is Dr. Musarakatani, who is a great colleague of mine. She's a pediatric nephrologist. She got her undergraduate degree at the University of West Indies in Jamaica, and subsequently got her Master of Medicine and Pediatrics and Adolescent Health at the University of Botswana, where she was also rotating at Wits University in South Africa. She also holds a Master's of Philosophy in Pediatric Nephrology from the University of Cape Town in South Africa, and she's a Fellow of the Pediatrician Society of South Africa. And she had a distinction award for her MPhil project, which was actually around the same topic that she'll be presenting today. And she's also a recipient of ISN Fellowship Certificate. And she's the first pediatric nephrologist who is currently practicing in Botswana. And we are fortunate that we'll be having another one coming soon. And she's also a lecturer at the University of Botswana, and she is an MMed coordinator for the University of Botswana Department of Pediatrics and Adolescents. And in addition to this, she also offers pediatric nephrology services in both public and private institutions in Botswana. And her academic interest encompasses pediatric acute kidney injury, nephrotic syndrome, genetics, bladder dysfunction, and urodynamic studies. And she'll be supported by Professor Lazarus. To just give a brief introduction of Professor Lazarus, he's a head of the Division of Urology at Groote Hospital and Red Cross Children's Hospital in Cape Town. And these are attached to the University of Cape Town. He has more than 20 years of experience in managing patients with complex pediatric urology and urological cancer problems. He leads a multidisciplinary teams in these fields, and he's an immediate past president and present secretary of the College of Urologists of South Africa. He's accredited National Research Foundation rated scientist. He's established Project Peacock, which is a non-profit organization which serves to promote access to prostate cancer care. He is also a founding editor of African Urology, a regional academic journal, and Advanced Urology Journal Club podcast. So during the presentation, Dr. Musarakatani will also be discussing with Professor Lazarus for his input. Dr. Musarakatani, down to you.
Thank you, Dr. Molloy. And I just want to also again thank Prof. Lazarus, who was also my mentor for my MPhil as well, for joining us and also coming in to give his expert opinion. So today, I think we're going to do it a little bit different from the usual because I have 3 cases. And because bladder dysfunction is something that is common but really unknown by both adult doctors and pediatric doctors as well. So I thought before we start with our 3 cases, is just to give an overview, because this is a topic that is really not known, and I only got to know about it even though as pediatricians we do manage kids with bladder dysfunction. I only got to know the depth of bladder dysfunction when I did my nephrology fellowship at Red Cross. So good evening, everybody, and thank you for joining. So I thought I should just start with this. Because we both have pediatric doctors and adult doctors. Somebody said pediatricians know everything about the outcome of their patients up to the age of 14 years. And I think in many institutions it's up to the age of 13, because that's the age where now we start talking about transitioning. And while adult nephrologists know everything about their patients from around the age of 16 years. And for bladder dysfunction, it is important to know everything that happened before the age of 13 years and everything that happens after the age of 14 years, because it impacts on the long-term outcome of our patients. So I have no conflicts, and permission has been granted to me to use pictures. And I want to thank Jeanette and Professor Mignon for some of the slides I've taken from them. So the first question, I don't want anybody, you can just put it on the chat box. I thought this was an interesting thing. It's taken from one of our urologists that I work closely with, Dr. Maher. He got this. So my question to you, what is the diagnosis that you see here? And how old do you think this patient is? So you can just put it on the chat box if you know. And the answer would be, I don't know if Moloi is seeing the chat box there.
Yes, I can see the chat box. There is no.
So a few months ago, my colleague, Dr. Maher, admitted a patient with benign static hypertrophy. So he did a scope for him, and voila, when he scoped, he's a 65-year-old man. And for the first time, the diagnosis of posterior urethral valves was made. So we all tend to think that posterior urethral valves are only picked up during neonatal or infancy, but this is a 65-year-old male with the posterior urethral valves, very rare. So for the adult nephrologists and adult urologists, know that once in a while you will meet a posterior urethral valve, and it's important to know where the natural history of posterior urethral valves, because posterior urethral valves are the #1 cause of bladder dysfunctions, especially in the pediatric population, and it does progress to adult life. And what you see in the pediatric population is not what you see in the adult population, because there is a transition that posterior urethral valves go through as they progress. So we'll talk about it with the case that we'll discuss. So for us pediatrician, bladder dysfunction, or for the definition of the bladder dysfunction, I make it simple, is any abnormalities with the filling, with the storage, and with the emptying of the bladder. So if there is any problem with that, you are right to diagnose your patient with bladder dysfunction. And usually most of our patients that come to us as pediatrician and also as adults, they come with urinary incontinence. So they have problems with controlling their bladder, which manifests as leakage or incontinence in the urinary system. So for the pediatrician, the most common cause, about 80% of our patients will have just normal bedtime wetting. And majority of them will actually resolve as they grow up. So with the bedwetting, the most common cause is a child who has polyuria, which we call nocturnal polyuria, because they have abnormality with the surge of the diuretic hormone at night. And also these kids are usually deep sleepers. So when we that's why we usually use the alarms to try to manage the bedwetting. And sometimes they can have overreactivity of their bladders in the nighttime. So this is the most common one that a pediatrician can treat, and they usually outgrow it. However, if these patients are left untreated, 18% of the children may continue to bedwet into the adult life. So for pediatricians, it's important that every child with bedwetting, you need to make sure that it's treated so that they don't continue into the adult life, because they have social impact. There's social impact and reproductive impact, as well as sexual impact of bedwetting into the adult life. So 18%, if not treated, they will bedwet. But most of the time, these kids don't come to us as nephrologists, or because they are usually treated successfully at the pediatric clinics. So now the ones that we talk about that we are here to discuss are the ones that have problems with incontinence at night, both at night and day, or a child who has incontinence during the day only. Because if we have incontinence during the day, there's surely some problem going on, and we usually divide them as functional. So one of the cases that we're going to discuss with Prof. Lazarus is the most common cause of incontinence that progress to adult life, which is the bladder overreactivity. So you will see the case with bladder overreactivity. And sometimes if it's not functional, we have those who are with neuropathic bladders. And most of the times are the ones with spina bifida is the most common cause of neuropathic bladders in our population. And we will discuss a case with a neuropathic bladder as well, because I think most of the time we tend to forget the bladder when we deal with patients with spina bifida. And lastly, the last case that we'll discuss is the anatomical abnormalities. And the most common cause of bladder dysfunction due to anatomical abnormalities in our population is the posterior urethral valves. And these kids you will see them in the adult population, and somehow we'll have to learn how to manage them as pediatrician and also as adult doctors, because they progress, like I say. So we're going to have 3 cases that we discuss. And why do both of us as pediatricians and adult doctors need to know about it? And why do we as nephrologists need to know about it? Because most of the time, the urologists, most of these patients are usually sent to your urologist, but we also as nephrologists, we need to know about bladder dysfunction. For pediatricians, it's important to know them because it affects the well-being and the quality of life of your patients. And in this day and age where our kids have to go for sleepovers, there is a social impact as well as mental impact. I think it saddens me to see in the newspaper where a child has committed suicide because of enuresis, and because we as doctors and as parents didn't take it into consideration. So we do have kids that actually commit suicide because of incontinence or bladder dysfunction. But importantly for us, we need to know about bladder dysfunction because of the fact that it is an important cause of chronic kidney disease in children. And most of the time, the end stage doesn't happen most of the time during pediatric population, but it happens during the adolescent time and the adult time. So adults really need to know about the bladder dysfunction. And there is little interest in how we transition our patients as well from pediatric care to adult care. So there's really little, and we really don't know what happens to our patients when they go there. So I thought it was important before I go into our cases to just show that this is because most of our bladder dysfunction are due to congenital abnormalities of the kidneys and the ureters. It was important to show that there is, you can see the timing and the outcome of renal replacement therapy. This is a study that was done from the European Renal Association and the European Dialysis Registry, where they looked at over 4,000 patients on dialysis because of congenital abnormalities. We used to say in the past that these kids, we're not going to give them. It was really hard to put them on the transplant list because managing a bladder was very difficult. But you can see here as well that majority of our kids actually develop or end up needing renal replacement therapy after the age of 15 to 19 years. So the adult doctors are going to see them more often as end stage than us. But also it's important to see that this one was just showing the outcomes when you compare them with the non-Kakut to Kakut, to show them the survival is actually very good when you compare them to non-Kakut. So, but it's very good when you manage the bladders, when you treat the bladders before transplant, and then there is also a meticulous monitoring of their bladders post-transplant. So they do quite well, and you don't lose your graft if you do that. And there's a nice case that we'll discuss, which is the posterior urethral valves that we have managed together with the Cape Town team to show how the progression is, and to show you that even before transplant, things can change with their bladder before and after transplant. So transition of care is very important. I think other countries, they have an adult congenital nephrologist and neurologist, and that's what our patients dream of having. But unfortunately, we don't have that in our setting or in the African setting. So we really need to be those adult congenital. We need to have that self-speciality within us, or we need to know about that, because that's what our patients dream to have. And they worry so much when they get transition that I've been receiving this care in the pediatric population with this multidisciplinary team. And we know what their worry is, what's going to happen when now I transition into the adult team. Where am I going to have that multidisciplinary team that I was having in the pediatric population? And this is a study that was done looking at the concerns of adolescents and adults with spina bifida. You can see that neurogenic bladder was actually at the top. It was not the neurology, which people often think. It was not the physical health or the orthopedic health. It was actually the bladder function and how they are going to coordinate care coordination as they move into the adult life. So urological issues and bladder issues are a concern for most of our patients with spina bifida. So our goals of treatment with every patient is to minimize and protect the upper tracts when you see this patient, is to improve the quality of life. And number 3, which we pediatricians often don't think about, is that we also have to prepare them to adult life, where we have to prepare them about their sexual and reproductive function as well. So I don't think we pediatricians often think about that as well. So I've put it as number 3 because we often talk about the top 2, where we protect the kidneys from kidney damage and we improve their quality of life. So now we're going to go into our cases. And I think this is the start for us to understand these 3 important cases, because these are the ones that you're going to see in your setting. These are the most common ones that an adult doctor will see. And I think these are the most common ones that are very difficult for us as pediatricians also to manage. And we also difficult to manage when they get into, they go into a stage where they need renal replacement therapy. So I'm going to start the first case. So the first case, it's a young girl. She's now an adolescent, 17-year-old female who we diagnosed as having an overactive bladder. But she's been having this urinary incontinence for 6 years now. And I think what usually happens in our setting is that we usually don't take incontinence or very serious, or sometimes we don't seek care when we have urinary incontinence. So when she came to us, the history was that she was having frequent voids and she was urinating every 30 to 60 minutes, during the day. And sometimes she will wake up at night, maybe twice or 3 times at night to urinate. So because she was voiding every often, and she was now in high school, this was distressing her and it was impacting on her social life and as well as her school life. And I think the last time when I met with her, she's closer to writing exams. So the concern was that when you are writing exams as well, you are given a time period where you cannot go outside to pee. So that was also her concern, that what's going to happen to me if I have to write exams and I will needing to or having an urge to pee. So with this frequency, she was also having urgency. So she will rush to the toilet to void. And sometimes when she reaches the toilet, she would have also had wet herself, just a small wet or a moderate wet to herself. So I think for us, we'll talk about some of the things that we can use, but in our settings that we do not have. So what usually happens when they come to us, we will do a proper history. But one of the things that help us to diagnose bladder dysfunction is the bladder diary. And with the bladder diary, we are looking at their frequency. There are several parameters that we look at in their bladder diaries, which is the frequency. You know, in a normal person, you and I should be going to the toilets between 4 to 7 times in a day. But you can see for her, she was having frequency going to the toilet about 16 to 19 times in a day. And then when you checked, because the bladder diary has a lot of things that you can get from the bladder diary. So when we checked her maximum voided volume, how much her bladder can hold, the maximum amount that the bladder can hold, it was about 45% of the expected bladder capacity. And for us to say that you have a normal bladder capacity, it has to be between 65 to 150 of your expected bladder capacity for that age. But for her, it was about 45%. So we were concerned about a small bladder. She was having urgency all the time, and she was having accidents also during the night. I mean, during the day. Night, not so much, but during the day, she was having accidents. So when we give you a bladder diary, because we know the bladder and the rectum, they go hand in hand. So we also gave her a stool diary. Remember, if you have impacted stools in your bladder, they compress on your bladder and they cause your bladder to have issues and decreases your bladder capacity. But her stool diary was quite good. She didn't have signs of constipation. So we also did a KUB ultrasound. Her KUB ultrasound showed normal tracks.
Tembi, unfortunately, we cannot hear you. I don't know if it's just me or if one can hear you. Hello, Doc.
Yes, hi,
Dr.
Walter.
Msalakatan?
MB seem
Hello?
to have disappeared.
She has disappeared. Okay, we lost sound. I thought it was just sound lost. Let me call her to see if she can come back.
Okay, I'm in. Sorry.
Okay, sorry, you can please share your slides. Apologies, we had lost Dr. Msalakatan, probably internet issues.
All right. Apologies, everyone. So I'll try to be quick. So she was leaving quite a lot. You are allowed to leave 5. When it's 10 in your bladder, we worry. When it's more than 20, we really worried. So she was also leaving about 30 mils in her bladder. So that was quite worrying. So at that time, based on the frequency, the small bladder, and the urgency, we made a diagnosis of an overactive bladder. And we started to manage her bladder by giving her fluids, because we were worried that her bladder was small. So we managed her by giving her more fluids during the day and decreasing her fluids at night so that she can increase her bladder capacity, and also to avoid caffeine so that she doesn't have so much frequency. Because she was voiding so much, we also told her to void frequently. And because she was leaving a lot of urine, there's something that we call double void, meaning that you void twice. So you void, wait for 50 seconds, and you void again so that you can clear whatever is left in the bladder. And because of the urgency and the fact that with overreactive bladder, there is bladder instability, we gave her an anticholinergic, and the one that we have is Vesicare. And I know in many African countries, we don't have most of these medications as well. So follow up, it took a long time to get her to see some response. So after a year, that's when we started seeing some response. We had to go back and forth to train her bladder. That's when now her frequency dropped to 8. And then when we did her bladder capacity, her maximum voided volume was 68, and she was not having frequent accidents during the day. So believe it or not, overactive bladders are very common. As you can see from this American study, it's even fourth after the chronic sinusitis, arthritis, and heart conditions more than asthma. So overactive bladder is there. And what they saw is that 1 in 8 of adults do have an overactive bladder, and 4.5 out of 10 don't seek care. They don't come and ask for care, and it does impact on their self-esteem, on their confidence, and also at intimacy. So one wonder why this 4.4 over 10 don't seek care when this overactive bladder is making so much issues in their quality of life. For us as pediatricians, there have been studies to show that if I don't treat an overactive bladder, the overactive bladder is going to have an impact in their adult life. Or a child with symptoms of overactive bladder, they will also have symptoms of overactive bladder in their adulthood. So it's very important that we have to make sure that we treat it there so that it doesn't progress there. So the diagnosis is simple. History, if you have frequency urgency, you have an overactive bladder until proven otherwise. And then we use bladder diaries as well. In settings where they have a uroflowmetry, they can do it. In Red Cross, they have urodynamics. A lot of people don't have it, and I think Prof. Lazarus will also share with us what can be done. But most of the time, if you do have a urodynamic studies, it measures the storage, the filling, and also the emptying capacity of the bladder. That's what the urodynamic studies have, and I wish every country had urodynamic studies, because some of these overreactive bladders can sometimes they are not straightforward. You can have an overactive bladder with a dysfunctional voider, and it's very difficult. And I think Prof. Lazarus will also discuss with us, because this child had a post-void residual that is a lot as well. Is this a patient who had a dysfunctional voider with an overactive bladder as well? So we'll discuss that with Prof. Lazarus, because this is the patient that I discussed. But if you have a uroflowmetry, it will give you this shapes of a graph. If you have a bell shape, it's normal uroflowmetry. But an overactive bladder will have this tower shape. And if you have a dysfunctional voider, you get this staccato type of graph. And those with an underactive bladders, they'll have this interrupted types of uroflow. The obstructive ones, the one like your posterior urethral valves, will have this plateau type of a uroflow. So this actually, if you are not sure of your diagnosis, or your diagnosis doesn't make sense, these are the things that you can use as well. So the management is general measures, which we did for our patients, where you do your urotherapy and making sure that your bladder is managed. You stabilize the detrusor muscles. And in places where they have sacral neuromodulation, which I haven't seen, they can do sacral neuromodulation, or you can add your anticholinergics to your marrow to increase the marrow helps really also to increase your bladder capacity. If all fails, I don't know if other people have they are able to use Botox. You can inject the Botox into your detrusor muscles to increase the bladder capacity. So I think we can just chat. We'll go back to this case so that we chat about when we don't have this, what can you do with an overactive bladder, with Prof. Lazarus knowing what we have in Africa and what we don't have in Africa. I'll rush through the cases and then we'll go back so that Prof. Lazarus can give his input. The second case is the one that I'm really passionate about, because when I got back from home from Red Cross, I could not believe the number of patients we have with posterior urethral valves. And then the sad thing was that these kids, they come in when they are teenagers. The majority of our kids come in when they are teenagers with incontinence. So I remember one of a patient, the teachers just came to me and said, you know, I have a student who is having incontinence, and sometimes there's a smell coming. Can I talk to the doctor, to the father, to bring the child? So we miss these kids, and sometimes some of them may die from urosepsis. And I know some of them, we might have missed them and you just said it's sepsis or something else. So this one, it's a case that we know from Red Cross, a 11-year-old male who was diagnosed with end-stage kidney disease due to a posterior urethral valves. And this patient presented at the age of 8 weeks for the first time with urosepsis, but everything that needed to be done was done. The KUB and the MCU confirmed that he had a posterior urethral valve, and at Red Cross they have a right side scope and for ablation, so this child got ablation. But because the bladder dysfunction and the bladder damage was so severe, the child did both ablation and vesicostomy. I think also Prof can touch on that you can do both vesicostomy and ablation. And the vesicostomy was closed at the age of 2 years. However, the child was lost to follow up. And I believe this mother did not just come, she just thought the child was healed. The vesicostomy was closed, the child was ablated, so the problem sorted. So she presented, this child was brought at the age of 11 years with end-stage kidney disease now. And when they come in with end-stage kidney disease at Red Cross, we have to assess if they are eligible for transplant. But this child was eligible for transplant and was on dialysis for 3.5 years, mainly because they didn't have a donor, a living-related donor. But during this time, because this child was eligible for transplant, we had to do aggressive bladder treatment prior to transplant, because a lot can happen and they can lose their graft if you don't manage their bladder. So we taught him how to do urotherapy. We did clean intermittent catheterization. We did overnight drainage and also bowel management. So when he came in, we did a urodynamic study. Remember, I told you that in other areas, a urodynamic study really helps. And every child with posterior urethral valves or every patient with a bladder dysfunction who is going for transplant, they need a urodynamic study. They really do need a urodynamic studies. And we'll discuss, Prof will give us an expert opinion on what happens if you don't have urodynamic studies, because I do have so many kids with posterior urethral valves with lingering end-stage kidney disease, and we don't have urodynamic studies in our setting. So we really don't know what's happening with their bladder function. We only know little. So when we did a urodynamic study, with the urodynamic studies, you are measuring the vesical pressures, and the abdominal pressures as well. And the difference actually will give you the detrusor pressure. So the top and the bottom one will give you the first one and the second one will give you the detrusor pressure. And also you have to look at their pelvic floor and what the pelvic floor is doing with relation to their sphincter by looking at the EMG, which is that black one at the top. So when you look at this child's capacity was normal. It was about 300 mils, which is normal for his expected bladder capacity. And his pressures were were adequate. They were not bad, but he was having incomplete emptying, hence the clean cache intermittent catheterization. So we start worrying so much, just like PVR. When the detrusor pressure starts going to 10, we worry. When they go to 20, we really get worried because they have a significant impact on your upper tracts. So they will damage your upper tracts. So he had a good, for us, this was a good urodynamic studies that we can take the child to a transplant. But voila, so look at this. This is pre-transplant. And look at now the post-transplant. I think even the people who don't know how to read urodynamic studies can see that there's definitely something wrong going on. So he now had this uninhibited, you see all these contractions. So he had numerous detrusor contractions as well. And also you can see when you are looking at the graft, there was also reflux into the graft as well. So his bladder was also always contracting, and this was also having impact on his graft, and there was reflux into his graft. So this patient was coming a lot of times with repeated UTI, and we really had to manage those and really had to manage the bladder as well. So with the posterior urethral valves, like I say, in my settings, we don't diagnose them prenatally. We usually diagnose them postnatally and at the adolescent stages because we do miss them. So in areas where there is strong antenatal or prenatal ultrasound, they can diagnose them prenatally, and they will see a large bladder with a large urethra or dilated urethra, and this is what they call the keyhole appearance. But when they are born, you can diagnose them using an ultrasound. If you have a MCUG, an MCUG is considered a gold standard for radiological investigation. But the gold standard for diagnosis is actually a scope. And with the scope, you can diagnose and you can also do a valve ablation. But in many settings, we don't have that. So we'll discuss this case again to see what we can do. So you can do antenatal treatment with the shunt. You can ablate once they are born. And in areas where they don't have ablation, they can do a viscostomy probe. We'll discuss that as well. So why did this child who we managed at the age of 8 years, 2 years, progress to end stage when we have dealt with the valve? The valve damage is done in utero. The bladder damage is done in utero, and it goes through a number of changes. So when they are still young, they go through a changes that we call a valve bladder syndrome. So they start off with a high bladder, small capacity, which is very spastic. And as they continue, the bladder, they get this myogenic failure, and they just get a floppy bladder that cannot empty, which is very large. And this predisposes them to infection, repeated infection, and renal scarring. So on both sides, they both get repeated infections and scarring, but for a different reason. This one is because the bladder is always active and spastic. The other one is because you cannot empty because the bladder is just floppy. And that's why urodynamic studies are important, because you need to know where in this area does your patient fall. So it's very difficult for us Africans to try to see exactly where these patients fall in terms of, because the management depends on where they are in the spectrum of valve bladder syndrome. And the treatment is in the neonatal period is usually the urologists are actively involved, but as they grow and progress into adulthood, us nephrologists become actively involved then, because that's the risk where they get so many complications related to that. And this was just to show survival, that they do survive if you manage their bladder function. So the last case, and Prof, this is the last case. This is a 12-year-old from Zim who presented to me last year with end-stage kidney disease due to neurogenic bladder, presented as a crash lender. They usually, most of the time, our patient comes as crash lenders. She came in with hypocalcemic seizure, severe metabolic acidosis, elevated urea and creatinine with a GFR about 4, with severe hypertension and severe metabolic bone disease. Background history is that she was born with myelomeningocele. We did a beautiful job by repairing it during the neonatal life. And this child was doing well, high functioning, walking independently without any support. But for the past 2 months before coming to me, was now having to use a wheelchair and was being seen by a GP for anemia. And this is a family who was very actively involved in their child's care. And this is a child who was thriving. But one thing that we forgot that we usually do is the bladder. So when she came, we didn't to assess why she had end-stage kidney disease. We had to do her KUB ultrasound. Her bladder was thickened. She had bilateral hydronephrosis, even though the other kidney was very small and looked dysplastic as well. The MCUG showed trabeculated bladder with a grade 5 VUR. And the MEC3, many countries don't have MEC3, but the MEC3, it does help in these patients. It just showed that the left kidney was the only one that was functioning and the right kidney wasn't functional. So we did aggressive bladder management while we are treating her end-stage kidney disease. So we started her on urgent HD and we transitioned her on chronic HD. So she's been on, PD, sorry. So she's on peritoneal dialysis as well. So the mom had to learn CIC, but this is a mom who is very there. So she learned CIC quickly and she's been doing CIC, and we prescribe an anticholinergic as well. And there's been bowel management with the stoma nurses. Now the issue is, this is a child with end-stage kidney disease. What are we going to do? Because we don't have the abilities also to aggressively prepare her bladder for transplant. So this is a situation that we'll face as well in our setting. So it's important that to know that nearly all the myelomeningocele, and this is for the pediatricians, because I know the pediatricians are here, almost all of them has a neurogenic bladder. And the leading cause of death in the kids with the spina bifida is nothing else but urological. It's not neuro that we often think of, because during the neonatal life, we always focusing on the neurological aspect, but the urologic disorders, which is a neuropathic bladder, is the #1 cause of death in these patients. And we often don't think about the bladder. And in the Europeans, they start thinking about the bladder after birth. So the parents, they manage the bladder aggressively. By the time the patient is discharged, the mother already knows how to empty the bladder using clean intermittent catheterization. I think we
Sorry,
as
Dr. Msakata.
Yes?
Sorry, Doc, we have 2 minutes to go.
Okay, I'm wrapping up. Yeah.
Thank you.
So I think we as Africans, we can learn how to, we need to make our own guidelines on how to manage neuropathic bladders, because some of these things we can't do in our settings. So before Prof. Lazarus just gives us some ideas in the overactive bladders, neuropathic bladders, and also the PUVs. I think in summary, it's important to just know that most of these patients that should be picked up in the prenatal ultrasound are not picked up, but we pick them up in adult life, where hence you can see that 65-year-old with the posterior urethral valves. And it's important to know that these patients, if we don't manage them, they'll have end-stage kidney disease in adult life, and the transitioning of care is important part of these patients as well. all in all, I think it's important when we deal with bladder dysfunctions with pediatric patients as well as adult patients, it's important to form a group. That's what I've learned from Red Cross, that when I got back home, I was told Dr. Moloi.
Thank you very much, Dr. Msakazan, for that beautiful presentation. We have about 10 minutes for Prof. Lazarus to have his input and then take some questions. Prof. Lazarus, he presented 3 cases. Please take us through your take.
Yes, thank you very much to Tembi and to the Afran executive for the invitation. It's a very interesting presentation, interesting cases. I'm sure there are lots of things that we can discuss. I suppose we could perhaps start with the first case that you presented, Tembi. You spoke about her young lady of 17 having overactive bladder. I suppose as a pediatric urologist, pediatric nephrologists, we feel quite special because we see lots of these kids who our colleagues know very little how to treat children with bladder dysfunction. And we have some very simple things usually which are required to get these kids who don't have any organic problems. They simply have a functional problem with their bladder. And parents have usually seen lots of caregivers who haven't been able to take things much further. I think that we were chatting this week on our grand round with Professor McCulloch, and she made the point that if only we were dealing with cancer, then people would listen to us. But we're dealing with the bladder and kidneys, and often our patients and their parents are not too worried about the bladder. But I think it is really a call to us to popularize the importance of bladder problems amongst GPs who know very little, usually, and to realize that amongst those children who we're going to see, some of them are going to have very severe problems with chronic kidney disease. And we want to be able to do some simple tests on these children to work out, are they got severe problems, chronic kidney disease, and not to forget those who don't have any serious problem and are going to be fine, but suffer the social stigma of having incontinence. So when we think about dysfunctional voiding, I think the first thing is that nobody knows what it is. Colleagues are mystified by this concept. And essentially, it is a pediatric bladder becoming an adult bladder. An adult has a coordinated micturition reflex. Pontine micturition center sends the signals down, causes the pelvic floor to relax and the detrusor to contract. We know this very well. But in some children, not very well understood why, that maturation to that coordinated reflex has not occurred. And that's really what is causing the dysfunctional voider. The natural history is that in 18 months, usually these problems settle. So that's what we can reassure our parents, that things should get better. And you do need to do your due diligence, and that's going to involve a dipsticks to exclude infection, and it's going to involve an ultrasound to exclude anything sinister. And then you're going to try and classify these children into 3 groups, perhaps 4 groups. Are they normal? And these are, or do they have the overactive bladder? Or do they have dysfunctional voiding? Or do they have an underactive bladder? That's how we think about dysfunctional voiding. And these are based on urodynamic studies. But I want to emphasize to not rush into doing urodynamic studies in these kids because they are neurologically normal. You're unlikely to add very much that a good history and some simple tests are going to tell you. And so if you've got a normal dipsticks and the ultrasound is okay, you're probably not dealing with anything sinister. So how are you going to manage these kids? Well, they need timed voiding. In other words, they must be told to void every 2 hours, and the parents have got to essentially put in more effort to potty train them. And you need to manage the associated problems, such as chronic constipation, consider prophylaxis if they're getting recurrent urinary tract infections, and consider using an anticholinergic medicine like was suggested for the 17-year-old girl. And I would expect that most of the children who managed in that fashion are going to get better. If they're not getting better, doing a simple flow rate or getting them to void and seeing that they empty their bladder can help you a little bit further. Physiotherapists who have an interest in these problems can be of some assistance. So those are the ways in which we would think about managing overactive bladder dysfunctional voiding. I don't know if there are any questions there. Happy to take some questions.
We can take questions at the end, Prof, so that we keep on time. Thank you. We can go to the next case.
Yes, sure. The next case is the case of a valve. I did, in fact, have a video because I think it's quite nice for colleagues to perhaps see what, if Tembi could stop sharing, then I can perhaps share the video, see if we can make this work. Let's see if I take this back. I don't know if that's sharing. Walter, can you see that?
Yeah, we can see it. Thank you, Prof.
Yes, good. So I'm very pleased to see that Tembi is working with a pediatric surgeon and a urologist, and hopefully they have access to these instruments. These are 8 French resectoscope. And you can see, I'm going to pause the video there because it's such a beautiful example here of the classic cystoscopic appearance of posterior urethral valve here. And we've got the bladder neck beyond that. And we're passing the scope through. The plia caliculi are well seen there. And I think the general audience will be interested in the view in the bladder. Look, there's terrible infection inside this bladder. But you can also appreciate how trabeculated and sick looking this poor bladder is with sacculation. So clearly a bladder that's been working overtime to empty through this posterior urethral valve. And then we use electrocautery to ablate the valve. I teach everybody that it's very important to be aggressive in terms of this, to resect thoroughly. And we would routinely bring these children back, irrespective of what the ultrasound showed, in 6 to 12 weeks to see that we'd adequately ablated at the first sitting, and perhaps take some more if the ultrasound was still looking bad. I think the challenge, I'll stop sharing that. The challenge, as with many things around the continent, is access to equipment and access to skills. But I'd like to assure Tembi that we are training 2 Botswanan colleagues who come from GABS, and they should be back with you shortly with the skills necessary to do a nice ablation.
Oh, that's great. You can take us quickly through the third case, the neurogenic bladder, Prof.
Yes. So I love the phrase, the crash lander. That's something I'm going to be using, Tembi. That's a great phrase to describe that you suddenly got thrust with this unfortunate young patient who has effectively been undermanaged with myelomeningocele. And I think that we reflect on the cases in our clinic. Broadly, these children get ignored. They are not the favorite patients that we want to have to look after. And so, unfortunately, social circumstances, provider care not being adequate, these children often do drift. And I've learned over the years in our spinal defects clinic, both in adult and the pediatric setting, that children who come from poor circumstances, ironically, in the country of South Africa, often do better than those come from the leafy suburbs. And you ask, why on earth? How on earth could that possibly be? Well, those who have access to our combined clinic at Red Cross get into the routine of doing intermittent catheterization, taking their pills, doing their bowel washouts, getting a regular ultrasound scan at the clinic, and they seem to do fine. Unfortunately, parents who come from need to access the private sector, nobody takes an interest in them, no one explains to them about the condition, and not infrequently they end up very much like Tembi's third case. So really it's a call to arms. Those of us dealing with neuropathic bladders, it's a devastating condition. It needs a team approach, and I'm very to see Brenda Joshua online. She's our hardworking stoma therapist who's provided thousands of children with the kind of basic education and advice related to catheter care, bowel washouts, etc., that's required. The majority of patients who are managed adequately like that are not going to need Botox, are not going to need to have augmentations of their bladder. If they're just given catheterization, anticholinergics, and remember, it doesn't have to be anything fancy. Ditropan is just perfect, and that's something like 30 South African rand a month, so very, very cheap medication. But perhaps I'll stop there and see if we can take some questions.
Thank you. Thank you very much to you, Prof. and Dr. Masanakata. And we have 2 questions on the chat box. We haven't had a lot of questions. Actually, there are actually more. Sorry. The first question was from Maila from Botswana. She wanted to know how we treat nocturnal bedwetting. I know if there can be a quick answer to that. We have only 3 minutes.
All right, 3 minutes. The first is you want to familiarize yourself with the actual diagnosis of bedwetting. It's called primary monosymptomatic nocturnal enuresis. So by primary, it means they've always had to bedwet. They can't have had some problem socially that's now started them to bedwet. That's not bedwetting as we know it. It must be monosymptomatic, so they can't wet during the day, because if they're wet during the day, we need to deal with that primarily before we attend to the bedwetting. So if we're happy with that diagnosis, usually it doesn't take an ultrasound to reassure yourself. It's a very classic history, no wetting during the day. There's often a family history, no UTIs. Then you're happy to manage it. Again, you can get a very long way with a bladder diary at night, star chart, advice related to lifting the child, making sure that they empty properly, avoiding sweet and salty foods at night. And then you're going to consider medication. We're lucky to have access to desmopressin, the melt version. And if that's not available, you're going to have to use second-line agents that you might have in your setting, such as anticholinergics, but they are not quite as good as the DDAVP.
Okay.
Thanks.
Thank you, Prof. There's a follow-up question to that says, when should parents worry? When should they start worrying when the kids wet?
Yes, I wonder if that's referring to bedwetting or dysfunctional voiding.
Yeah, bedwetting. Bedwetting.
Yes. Well, I think the question really is when should you start treating? You're not going to be treating a 3-year-old who wets the nappy at night. So European guidelines, the European Pediatric Urology Guidelines, recommend from the age of 6. So I don't like treating kids before that. You're often under some pressure from parents, but I would try the non-pharmacological measures up until the age of 6. After 6, I'm happy to start meds.
Thank you. This will be the last question. I think it will be for Tembi. It says it's about the transition from pediatric to adult nephrologist. Dr. Yannick wants to know if we think this is something that is achievable in the African context.
I think anything is achievable, and I believe it is achievable in the African context. I think the main thing, like I say, is just trying to have a team. And if you are having a team, in my setting, my team, Dr. Moloi, is my team. So if you have a team early on, you can start introducing these patients to the adult care and you can share the information as well with the adult nephrologist. So if you have a team of both an adult and a pediatric team, I think it's very easy to transition your patients from the pediatric to the adult, because you are forever working side by side with the adult doctor. So I do believe it is very possible to have good transitioning in African setting.
Thank you very much. If we didn't take your question, it's not because of anything or no hard feelings. The questions were many, and I think we took the ones that we thought were pertinent. And thank you very much for both presenters, and thank you very much also to the Young Nephrologist Committee for putting together this presentation. We are now 1 hour into this talk, so this is where we would end it. If you have any more questions, I think you can still contact Dr. Msadakatane, Prof. Lazarus, just to get more insight into this case that we presented. Very, very interesting, something that we don't talk a lot about, but it's actually very, very important for our patients. Thank you.
Thank you. Thank you.